This patient has recessions on his canines, central incisors, and one of his lateral incisors. His request is related to aesthetics and to dentin sensitivities. This patient has a thick biotype, and if we used a continuous graft on the right side, it would be relatively unattractive because it would thicken the base of the papillae. On the left side, in any case, a small graft is necessary. The idea here in this type of case where we have a relatively thick biotype, both for reasons of tissue economy and aesthetics, would be to treat all these recessions with micrografts. The first instrument we use for tunneling is a tunneling knife, like here. It's quite a complex tunneling because there is a lot of keratinized tissue. And these are emerging recessions, especially on the central incisors. There aren't any on one of the lateral incisors. Therefore, as we saw during the course, tunneling this type of patient is quite complex. So for these complicated cases, either we add a lateral incision, here it is not necessary since it is not that complicated, or we use an instrument that is normally not dedicated to this. It's the papilla elevator. It has a curve that is quite interesting in this type of situation. Especially since there is a bone balcony. We can use this papilla elevator and then resume a normal course of tunneling with a tunneling knife. The production of a tunnel is schematically the design of several pockets, as many pockets as there are to be treated inside the tunnel, plus one on each side to allow laxity. We will then unify the design of several pockets to create a tunnel. Here, at the level of the canine, the amount of residual keratinized tissue is relatively low. So it is clear that tunneling on the canine is much easier than on lateral incisors or central incisors. This preparation can also be done with a blade, a microblade to be more precise. Personally, I prefer not to use microblades for this phase of treatment. I like these instruments. Whether it's tunneling knives or gingival knives, because they are less dangerous and we have a better control over tunneling. The palate has already been anesthetized. We are increasing the dose of anesthesia at this stage of the procedure to ensure that the patient does not suffer. Just a little thing here. We see that at the level of the first molar, there starts to be a recession. In these type of cases, you should not get too close to this recession because maybe there is no bone underneath. We don't want to risk increasing the recession after harvesting. So here we are, we have harvested the graft. It is continuous. We will incise it, cut it into several subgrafts, where each of the subunits is present on screen. The larger ones are intended for the canine, which has the largest recession, the right canine for the patient, the right central incisor as well, and the smaller units are intended for the right lateral incisor, the left central incisor, and the left canine. The insertion of the micrografts is done through the modified belt suture. So we enter inside the tunnel, we retrieve the graft through a U-shaped stitch, which you can see on the screen. Then we will go back into the tunnel, position the graft, and complete the belt stitch. So here's the U-shaped stitch. The sutures are positioned in such a way that the graft will be perfectly covered, but its marginal edge will be perfectly aligned with the marginal edge of the flap. The biotype change brought by the graft must be effective from the first millimeter of tissue. We perpendicularly pull to the axis of the operated plane, which opens the tunnel and allows the easy insertion of the micrograft. Suturing continues. We go palatally above the contact point, come back to the buccal side through the embrasure, pass in front of the buccal surface of the tooth, and go back to the palatal side. Through the embrasure, and then we return to the buccal side to tie the knot. It's the belt and suspenders approach. The contact points are sufficiently sealed. There is no need to add composites in the proximal areas to retain the sutures. This type of procedure is typically done with a 6-0 monofilament thread. In choosing your thread, be careful that the needle corresponds with the thread. Sometimes you find very fine threads with quite large needles. Of course, this is not good for the tissues and must be absolutely avoided. So there must be consistency between the size of the needle and the size of the thread. Always the same procedure for inserting the micrografts. This modified belt stitch allows both the insertion of the micrografts and to perform an initial pull that will be increased at the end and better distributed by adding the suspenders. Here, the selected case presents relatively limited and small recessions. It was chosen for this reason because things are much more complicated in reality when the recessions are of limited extent, especially during tunneling. But whatever the size of the recessions, it makes no difference. Tissue displacement occurs with the same ease. In this particular small recession, we need to help the graft just a little bit. This means that this micrograft should neither be too buried nor exposed. And so, of course, there must be a correspondence between the entry and the exit points at the level of the graft and at the level of the receiving site, at the level of the tunnel, actually. And so here is the situation at the end of the surgery, belt and suspenders on each tooth we worked on. And here is the situation 2 weeks after the surgical procedure. The suture threads were removed 1 week earlier, so 1 week post-op. The patient is seen again at 2 weeks for both checking the healing and giving instructions to go back to normal cleaning and to remove the plate at the palatal level.